I think we are almost ready for our next exciting session, our fireside chat with Founders Award winner Dr. Weiss. He will give us a brief presentation, followed by his interview conducted by Dr. Shelley Greenfield, who is the winner of last year's Founders Award. We look forward to a great session, and I'm going to hand it over to our AAAP President, Dr. Mooney, who is going to introduce Dr. Weiss.
Good morning, everyone. I am very excited to have the honor of introducing Dr. Roger Weiss to you all today. Dr. Weiss is a professor of psychiatry at Harvard Medical School and chief of the Division of Alcohol, Drugs, and Addiction at McLean Hospital. He has been principal investigator on numerous NIDA and NIAAA grants and has developed integrated group therapy and evidence-based treatment for patients with co-occurring bipolar disorder and substance use disorders. Dr. Weiss led a multi-site national study of the treatment of prescription opioid use disorder as part of the NIDA Clinical Trials Network and is currently a lead investigator on the multi-site retention, duration, and discontinuation study, which is examining optimal treatments for opioid use disorder. This morning, he will be presenting his talk titled From Addiction versus Psychiatry to Addiction Psychiatry, A Career Journey. Dr. Weiss, if you'd like to join me on stage to accept our Founders Award in recognition of your unwavering support of education, treatment, and policies supporting those with substance use disorders and co-occurring psychiatric disorders, your knowledge, relentless work on behalf of the Academy, and advocacy for the field of addiction psychiatry have had far-reaching benefits for medical students, fellows, and those in their early careers and the patients that they treat. Thank you.
Thank you. Thank you, Larissa, and thank you to the folks who nominated me. This is really a great award because AAAP is my favorite organization, and as someone in this audience once said, addiction psychiatrists are my favorite people. So getting an award from AAAP really means a great deal to me. So, here's my disclosure. So when I got into the addiction field, it was 1980. People often ask, how did I get into it? What led me to be interested in addiction? And really, I got into it because I was escaping from another job. I had another job, and I didn't like it, didn't like the people I was working with, and I told myself, the first offer I get, I'm out of here. Turns out, the first offer I got was to run an addiction program at McLean Hospital. And I didn't know anything about addiction. I had never, at the time I said I've never treated a patient with addiction. I should have said I've never knowingly treated a patient with addiction. I'd probably treated hundreds of patients with addiction, but who asked? I did have 1 hour lecture on alcohol in medical school and 1 hour seminar on opioid withdrawal in residency, so I was pretty well prepared. And I didn't know anything about research either, and I was told that this unit would be doing research. And I did have a 1 hour seminar in medical school on research where we had to read an incomprehensible immunology article and talk about the methods. So at that time, addiction was really seen as there was no interest between psychiatry and addiction. There was only mutual distrust at best. Mutual antagonism was really more like it. So I thought if you couldn't get a job, you could work in addiction. And so I thought, here I am, I'm not quite 30 years old, and I've ruined my career, because now I am running a program I don't know anything about, supposedly doing research when I don't know anything about that. I was asked to pick a research area, and the first 3 patients that showed up all had cocaine use disorder. It was the beginning of the cocaine epidemic of the 1980s. So I said, okay, that's my area, which was very fortunate. The one thing I did know about was how to do psychiatric evaluations. And so a lot of these patients had psychiatric illness. And so I ended up writing up things like a lot of patients with cocaine use disorder, called cocaine dependence at the time, have psychiatric illness. And that was news back then. That was news, and not welcome news. It was very controversial, and I remember giving a talk once reporting that and having someone stand up and say, "Who the F do you think you are telling me I'm crazy?" So that was what it was like back in the day. Back at this time, alcohol and drug programs were completely separate. There was no such thing as addiction psychiatry. Those 2 words went together like addiction furniture, addiction bicycle, addiction psychiatry. They had nothing to do with each other. There was no AAAP. Addiction was the bottom of the barrel career choice for people who couldn't do anything else. The cocaine epidemic was just starting, and at that time was largely an upper middle class phenomenon. There were 2 pharmacotherapies in the world of addiction, methadone and disulfiram, and psychotherapy was never used in the same sentence unless the word contraindicated was also in that sentence. So we were supposed to be doing research. So we did, but we didn't have any money or any research staff. So what we did was the nursing staff would do Hamilton Depression Rating Scales, Beck Depression Inventories, SEL-90s. The night staff scored them. Of course, these were all on paper because we didn't have the money to buy a computer, and we had a room that we piled up all of these paper forms. There was nothing else in the room but these forms that just piled up, hoping one day somebody would give us some money to, A, buy a computer and hire somebody to do something with all of this. And at some point, they did, and we bought a computer, we had a part-time research assistant, someone to analyze the data. I had a great mentor named Steve Mirren, and when I told him I don't know anything about addiction, he said, "There's not much to know," which was true at the time, "and whatever you need to know, I will teach you." And he said, "If you really want to learn about addiction, run a group every day," which I did for about 2 years. And that's where I really learned about addiction. And I'm going to talk more about mentoring when I talk with Shelley. One thing that I was very clear about was that I was never going to write a grant. That was something that researchers did, and I was really a clinician that did a little research on the side. But we did a lot of research on all these people who were in our inpatient unit, but after about 9 years, there was really nothing else we could do. We got every piece of data we could get from people who were in the hospital for 4 weeks back, which is what it was back in the day. And so I finally wrote a grant in 1989 on predictors of outcome in cocaine dependence people leaving the hospital. That was the same year of the first AAAP meeting, which was not called AAAP at the time, it was called APA, American Academy of Psychiatrists in Alcoholism and Addictions. So then I started sort of slowly but surely shifting more and more toward research. NIDA, National Institute on Drug Abuse, put out a call for a multi-site trial of psychotherapy and counseling for cocaine dependence. And I knew a lot about cocaine by that time, so I applied for that and got it. And that's where I really started to learn how to do research on a very different level. With a lot of experts in the area of psychotherapy research and statistics and a variety of other things, I started to learn how you do these things, including the technology of how to develop a behavioral therapy, how to test it, et cetera. Soon after that, NIDA started the Behavioral Therapies Development Program, which was a parallel track to the medication development program that they had had for many years. And psychotherapy was no longer contraindicated, but it was seen as a potentially important tool in the treatment of patients with substance use disorders. So I decided to put in a grant to develop a new treatment, integrated therapy for patients with co-occurring substance use disorders and bipolar disorder. And I was very fortunate. I got 3 grants to test it in a variety of different ways. It turned out pretty successful, and now we use it a lot at McLean Hospital, and it's actually in use in a variety of other settings, and now in several other countries that I know of: Canada, France, Switzerland, Nepal. So that feels like something I was quite proud of. Meanwhile, back at the ranch, addiction psychiatry had become a real thing. In 1996, APA became AAAP, the American Academy of Addiction Psychiatry. That was now a term that people used. You could be an addiction psychiatrist. I served as the program committee co-chair, first with Tom Costin, then with Rick Reese. And these meetings were really different back then. It was all plenary lectures from luminaries in the field. There were no workshops. There were no papers by members. There were no posters. It was just more like a board review course. You sat and there was one lecture after another. Our goal was if we could get 200 people to come, then we wouldn't go broke. And I used to call the executive director every week, how many people do we have? How many people do we have? And we barely would make it over the 200 mark each year, but it was, the stakes were really pretty high. But these were clearly my favorite meetings, mostly because of the people, and I made a lot of lifelong friends coming to this meeting, and and it's really the key reason that I liked coming to this meeting more than anything else. The next thing I ended up doing was doing my first alcohol study, the National Institute on Alcoholism and Alcohol Abuse combined study. It was a big multi-site study, 11 sites, 1,300 plus patients. It was the largest study of its kind, testing combinations of medications and behavioral therapy. So people got either naltrexone or acamprosate or both or neither, all with and without psychotherapy. And naltrexone had a positive outcome. Behavioral therapy did. No combinations did. And acamprosate did not, which was very disappointing to us. We really welcomed the opportunity to bring acamprosate into the U.S., and it helped to kind of dim enthusiasm for acamprosate in the treatment of alcohol use disorder. While I was doing that, an envelope dropped into my mailbox with a request for applications for the NIDA clinical network that the head of our department sent that with a little sticky note that said, "Roger, apply for this." So that's what I did. The Clinical Trials Network, or CTN, is a partnership between addiction researchers and community treatment providers and general medical settings to develop and conduct multi-site addiction treatment studies. So I was originally the principal investigator of the Northern New England node, which consists of a research center and a bunch of treatment programs. And then we merged with Yale, and it's now the New England Consortium node. And as part of that, I led the prescription opioid addiction treatment study, which examined different lengths of buprenorphine treatment and different intensities of behavioral therapy. And we found that longer buprenorphine treatment, as opposed to just tapering, had much better outcomes. And adding counseling to medical management and buprenorphine did not improve outcome overall, though some groups benefited from more intensive behavioral therapy. And one really nice thing about this is it actually changed a lot of policies. One state that had set a cap on buprenorphine treatment at 1 year lifted the cap. One of the Scandinavian countries that did not allow maintenance, opioid agonist treatment maintenance for prescription opioid use disorder, changed that policy. And Hazelden, which had never had maintenance treatment, actually awarded that paper their most important paper of the year and changed their policy and started doing maintenance treatment. So that ended up being a really impactful study. The current study that I am co-leading with Drs. Nunes and Rotrosen is the retention duration discontinuation study. It's a large study, part of the CTN and the NIH HEAL initiative. It's 2 studies in one. The retention phase of it is to try to improve retention in medication for opioid disorder, and the discontinuation stage is the first prospective study to examine patients who are stable on buprenorphine and have decided to discontinue their medications. So this is 18 sites, well over 1,000 patients, and we should have results in early 25, I think, for retention, and about 1.5 years later for discontinuation. So just a couple of closing themes. Keep your eye out for unexpected opportunities. Grab them when you can. Find a good mentor. Most importantly, work with people you like, and you'll like coming to work. Work with people that you don't like, and you'll be miserable every day. And go to AAAP and get involved, and you'll be glad you did. So I will stop there.
So thank you, Roger, for that great talk.
Thank you, Shelley.
And great overview. And I just want to say what an incredibly great honor and pleasure it is for me to be up here to have this, what we're calling a fireside chat with Dr. Roger Weiss. For those of you who don't know, I really did start my career working with Roger at McLean Hospital when I was a resident. We did 2 months of addiction psychiatry as an intern, as a PGY1, and that's where I did my addiction psychiatry rotation, and it was with Roger. And ultimately, when I completed my training and came back as a junior faculty member, Roger became my first research mentor as I began my career as a physician scientist. And so it's an incredible pleasure to have an opportunity to be here to talk more with Roger about his career and some words of wisdom he might have for others who are in our field. So, to start, you know, as a very accomplished individual and a national leader, what advice would you give to more junior colleagues who wish to follow a similar path to the one that you've carved out for yourself today?
So the first thing I would say is follow your own path, not my path. Because you may want to do some of the things I did, but you may want to do something else. So try to figure out what you want to do. as I think about that, you have a long career. Most people finish their training when they're in their early 30s. So they're going to have 30, 40, 50 years to practice. And there's going to be a lot of twists and turns involved. There's a great saying that is attributed to John Lennon, which is, life is what happens when you're busy making other plans. So things will come up. You'll be doing something, and they may be good or they may be bad. You may get recruited to something that never occurred to you but sounds really cool, and you'll go in that direction. You may be working in a hospital and they decide to open or expand an addiction treatment program, and they'll ask you to run it. Or you may be working in an addiction treatment program and the hospital decides to close it. You may get sick. Someone in your family may get sick. All sorts of things happen that will affect what you're doing. You may be doing research that NIDA and IAAA isn't interested in, and they get a new director, and this becomes their top priority, or vice versa. So I think a big part of it is, if you've got an idea of what you really want to do and it's something you would really love, go for it. You've got a long time to try things, make mistakes, succeed, fail, go back and forth. I think if what you want to do is research, if you want to be involved in the research world, there's more than one way to be involved in research. You can be someone that likes writing grants, or you may be somebody that doesn't want to write grants. It just doesn't fit whatever other interests and priorities that you have. And you can have a great academic life involved in research. You can be a study doctor, you can be a co-investigator, there's all sorts of ways people can be involved in research without writing grants, doing a lot of teaching, and have a very academic job. Research is a high risk, high reward. Grant writing is high risk, high reward. Writing a grant that you get is highly rewarding. Writing a grant that you don't get is not rewarding in the least. It's a kind of miserable experience. Oh no, like nothing. And there's no partial credit. So it's, you have to, so what that means is, for people who are writing grants, I'd always ask people, what's your plan B? And whenever I wrote a grant, I always thought to myself, if I get this, that's great. If I don't get it, I'll see more patients, which is fine. I like seeing patients. Which leads me to say, regardless of whether you're doing all clinical work, or mostly research, don't give up your clinical practice. For a couple reasons. One, you may need it. But even if you don't need it, even if you're funded really well, if you stop seeing patients, your research is not going to be as impactful or interesting. Where are you going to get your ideas? You get your ideas by seeing patients and realizing, I'm not sure what we should do here. And this is actually a pretty common situation. We should study this, and I know how to study it, and I know how patients will respond to a study of it. So people, I think it's always important to stay in touch with patients. Last thing would be, lots of people say, I want to do half clinical and half research. what you're really saying is I want to do 80% clinical and 80% research, because you can't do it that way. First of all, you're competing with people who are doing all research, and if you're not, you're at a disadvantage. And the other thing is that unless you're doing shift work, your Monday patient is going to take up your entire Thursday when you're not seeing patients, because your patient is unstable and needs, who knows what. So everything leaks into everything else. And so you have to be very careful. If you want to do research, you should be doing 75, 80% research. Not that you should be doing 80%. I'm not telling anyone you should do research, but if you're going to do it, you got to commit to it.
So thank you. So I think that this is just a lot of words of wisdom around how you think about carving your own path through your career, and also how you think about the fact that there are many things that occur that you don't plan for, and how you accommodate those as you move forward in your career. So it leads me to another question, which is, and you alluded to it during your talk, which is the role of mentorship and mentors. And I'm wondering if you could comment on the role of mentors and mentorship, and also comment on any significant mentors you had that you thought were really pivotal in your own career, and how were they helpful to you? In what way?
So my mentor was Steve Mirren. So when McLean decided to open an addiction unit, he was the only person that knew anything about addiction, and he knew a lot about addiction. And he was asked to open this unit, and he said he would oversee it, but he didn't want to run it day to day, so he asked me to do it. Even though I told him I thought I was the wrong person for the job because I didn't know anything. What made him, how was he helpful? He was helpful in a number of ways. First of all, when I was trying to figure out, should I do this? I talked to the chief of the hospital at the time, because there was another offer I had to work with somebody else, not this first person I worked with that I was trying to get out of, but there was another possible offer. And he said, and I think this was like the key thing about the mentoring, is he said, Steve will support you and will help you to grow. And this other person, if you look at the people who have worked with that person, they're stuck. They're not, they're always working with for that person, and it's clear what the pecking order is. So I think what Steve did, and what I think good mentors do, is a little bit like what a good coach of a sports team does. Before this year, the New England Patriots were actually a good football team. And Bill Belichick, one of the most popular men in America, was the coach. And they always talked about what made him so good. And they would always say, he put his players in a position to succeed. So he would take people, from other teams that were not doing that well, and he said, if I put this person here and have them play this position, they'll do better. And I think that's what a good mentor does. They put you in a position to succeed, then it's up to you to do it. So how did he do that? First of all, just telling me run a group every day if you want to learn about addiction, that was brilliant advice. That's where I really learned, what goes on in these patients' heads and in their lives. And the next thing he did is he said, pick a research topic. That will be yours. And that was mine. If there was a paper to be written about cocaine, I was the first author, period. The next thing he did was a few months into my starting to work on this unit, he had written this long book chapter on all of the major substances, and the publisher asked him for the next edition. And he said, sure. And then he said, Roger, you do it. You may be familiar with this, Shelley, because when the third edition came up, I said, Shelley, do you want to do it? So when you have to write essentially a 100-page book chapter, you really learn a lot about the field. And so once I did that, and of course this is before computers, so like, you know, longhand, it was like the dark ages, and I really felt like I know a lot now. And I was 6 months in, and I went from feeling like I don't know anything to ask me anything, and you know, and I loved it. I mean, I loved this job, even though I had no, you know, went into it completely bewildered. I loved it from day one, and I think a reason I loved it is I loved the patients; they were great. But I also loved the staff, and you know, Steve helped create a great atmosphere, and it was fun. We laughed a lot. You know, I always feel like if you laugh a lot, you're doing good work, and we laughed a lot. So he then, other things that he did, we'd go to a meeting like the APA meeting, because there were no AAAP meetings back then, but we'd go to the APA meeting, and he'd be going out to dinner with people who were, you know, above me, Herb Kleber, Chuck O'Brien, people who were sort of eminences, and say, Roger, why don't you come along? So I would get to meet these people. And, you know, Herb Kleber, you know, said, if you want to work with me at Yale, I guarantee you we can pay you less than they're paying you at McLean. So I got a job offer. That's how he sort of opened things up for me. He got offered the American Psychiatric APA Publishing, contacted him and said, we'd like you to write a book on cocaine. And he said, he told me to do it, and I was the first author. So, which was a big deal, you know, to write a book. So really opened doors, very critically edited what I wrote, like really critically. So I tell people this, and people who are young enough, it sort of blows them away. Back when the words cut and paste meant that you cut the page and then would paste it onto the page, and so I would write a first draft of a paper and it would come back unrecognizable. I'd say, where's page 2? No, that's page 4 now. And it was sort of, it would come back much more red than black and white.
Yes.
So he didn't just, you know, no lazy revisions. It was really learning how to write a scientific paper. You know, I wrote good college papers, but, you know, he taught me, throw that out the window. You know, you're writing a very different way. Mm-hmm. And nobody's born knowing that. And he really taught me how to do that. So there were all sorts of, everything from just encouragement to introductions to very technical knowledge. He just helped me in all those ways.
Yeah, thank you. And I was thinking that I think I did write that third one.
Yeah, you did.
The third round. And also it made me reflect that when I was writing all of my first papers and also my first grant, at that point there were computers, I was typing them, but I was printing them out and they came back from you absolutely just completely red inked in every possible sentence. There was nothing recognizable. So it's a kind of see one, do one, teach one in a way, in a different kind of a way in terms of mentorship. You know, having a mentor and who does those things to becoming a mentor to do those for your next generation of your mentees. And, you know, I wonder if you could reflect on how you've overcome obstacles, because we all, you mentioned this when you were talking about things that come up that are not anticipated, and everybody in their course of their lifetime, their personal life and their professional life, will have obstacles, will have setbacks. And I'm just wondering through your journey, how you've overcome obstacles and what lessons you've drawn from those things and what you can share with others.
So before I answer that, I want to go back to one other thing about mentorship, which is being a mentor as opposed to having a mentor. Because that's so much fun. Being a mentor is great, and at some point, you become the mentee of the person that you were the mentor to. Because if you're doing your job, they're developing their own thing that they now know much more about than you do, and they're teaching you about things that you don't know so much about. And it goes from mentor to colleague to sometimes mentee about other things, and that's part of the fun of all of that. Obstacles, challenges, setbacks. So there have been some bumps along the road. So about a year into opening this drug addiction unit, I got a call from the person that was the director of Bridgewater State Hospital, at that time called the Bridgewater State Hospital for the Criminally Insane. Not the most desirable place for anyone to work. And he said, "I hear you're looking for a job." And I said, "No, actually, I'm working on this addiction unit." He said, "Oh, I've heard it's closing." I said, "Really?" That's how I heard that our unit was supposed to close, because of some politicking that was going on at McLean, and we were losing money because we were a small unit, and even when we're full, we lose money. And so that felt like a bit of a setback. And I thought, well, what am I going to do now? I really liked what I was doing. And so I had a little bit of a crisis for about a month, and then everything changed, and they said, essentially, never mind, we're not going to close the unit, we're going to expand the unit, and then it won't lose money anymore. But that felt like a setback. That just flashed into my mind when I hadn't even thought of that in 40 years or something, but when I thought about setbacks, that kind of came to mind. But there were a couple things. So when I was the program chair, one of the symposia that we put on was one entitled "The Other Addictions, ? Gambling, sex addiction, and eating disorders. Are these addictions?" And I thought it was kind of an interesting symposium. I was chewed out publicly, told you are going to sink this field by sort of cheapening it. These aren't real addictions. We're trying to gain some sort of recognition here, and you are undercutting everything we're doing. That felt a little like a setback. Another setback, I was trying to go from assistant professor to associate professor. And I thought pretty sure I was going to get it. And I met with Steve Mirren, who said that he had sought letters of recommendation. And one person that he sought recommendation said, no, I'm not going to write him a letter. He hasn't accomplished enough. That really felt like a blow and sort of a wake-up call, like, I thought I was doing well. I guess I need to write more papers. I guess I got to get another grant. I guess I've got to do, whatever it was that I had to do, I had to step it up. And that was a bit of a crisis. Like, I wanted to murder the guy. So that was, I decided not to. But that was my first thought. Then I could have gotten promoted because other people would have written good letters. But I really, at that time I was thinking, do I even want to keep doing this? I sort of said to myself, I'm doing my best, aren't I? Or am I? It was like one of those questions. And I said, okay, I guess I got to do more. I would like to keep this thing going. But that was a big part of Steve's being a mentor. He said, you'll get to professor if you keep going. You can do this. So that was another, it was a sort of a big mentor role, which is when you have fallen down to help pick you up. But he didn't pick me up. He just said, I'll help you up, but you got to get up. And so I did. But that one sticks in my mind more than any of them, because it was a real career turning point.
Yeah. Well, I think it's really good to have the chance to hear about that type of experience, because I think everybody has that type of experience. And I think, I'm guessing everybody here can relate to that in some way or another. And I think one thing that I take from that is that, in the face of these things, having someone, as you said, to help you get up is critical, but also it seems to me that figuring out what you want and deciding to persevere in spite of that is also really critical, and I take that also from what your comments are.
Yeah.
So I was thinking, another question, maybe you've sort of answered this, but maybe you have other thoughts about it, is what do you think was, I know it's hard to think about it this way, but like one of the most pivotal, if not the most pivotal moment or experience that you had that led you think, to where you are today? And you've described some of the most early things, but are there other things that you think of as really pivotal experiences that have, led you to this point in your career?
Well, clearly the most pivotal one was this job offer to get into the addiction field. I mean, if I had liked my first job, I don't know what I'd be doing, but it wouldn't be this. I wouldn't know any of you people. And it's, I never would have gotten into addiction. It just never would have occurred to me. So that's like the, number one. But I think along the way, some things that were big events, that sort of turbocharged my career in a sense. Like getting into the clinical trials network was a huge shoot. So opening up this envelope, with the request for grant with a little yellow sticky note, apply for this, when I really didn't want to. Because at the time it was a 45-page grant, and you had this huge section on data management, which I didn't know even a thimbleful about data management, and you had to write 15 pages on it. And the idea of writing this grant just seemed so impossible. But I managed to sort of, scramble, and I was told by a colleague of mine, don't do this, they'll never give it to you, because, we already, there's already, one in New York and one in New Haven. They don't want too many too close. But I did it, and I got it, and then I think what sort of shifted my career, in the last 10, 15 years, it's been on opioid use disorder. And that happened through just sort of luck. And so when I was sort of early in the clinical trials network, we were asked, all of the principal investigators were asked to write a little three-page proposal of what they think the CTN should do. I wrote one on integrated group therapy, do a multi-site trial, which people liked the idea, but Dr. Volkov, who ran NIDA, didn't like the idea. She thought it had already been shown to work and didn't need any more. But what she thought was a really important study was a study of prescription opioid dependence, which had been proposed by someone else, Walter Ling, who's a big opioid researcher. He proposed it, and she announced at a steering committee meeting that that was her top priority. However, Walter Ling was already leading another study, and you weren't allowed to lead more than one study. So I was in some small meeting, and Dr. Betty Tai, who runs Clinical Trials Network, said, well, we really need, we need to do a study on prescription opioid dependence. Walter Ling was the one that proposed it, but he can't do it. Roger, you're new. You're not doing anything. Why don't you run it? And that turned out to be just a fabulous thing. I'd never done a study on opioid addiction. I'd never led a multi-site study. I'd been in multi-site studies. So this whole thing was really quite daunting. But this is what I mean, opportunities are there, grab them. It's one of these things where there's only one answer. Yes. It's like, I remember my daughter took 5th grade dancing class, and the teacher said, if someone asks you to dance, there's only one answer, which is yes. So when the person running the program asks you to run a study, there's only one answer, yes. And then that just turned into a whole, that has been the biggest part of my career ever since. And now I'm doing this other opioid use disorder study. So I think one other thing, this sort of reminds me that one of the things that makes a job interesting is if you get to do different things. Whether it's doing research on, it's not like I'm going to go do research on, cell lines or something like that, but something I don't know anything about. It's always going to be something in the substance use disorder, but I've done some cocaine research and alcohol research. They're very similar, but a little bit different, and it keeps things interesting.
Yep. So in that regard, you do a lot of things. You are a researcher, but you also run a big program. You're a fellowship director. You ran a treatment program for a long time. So in that regard, this is a little bit of a different question than what we've been discussing, but it's really important when you're doing those things to have a way that you can foster teams, foster collaborations within teams. And I'm just kind of wondering how you go about fostering a sense of camaraderie, a supportive group, and how do you foster collaboration and create a supportive environment for the groups that you're, running and supervising and leading? Because I think that's a very important question for everybody, no matter what they're doing in our field or any field for that matter. So I'm just curious about the way you think about that.
So I think about the way, sort of going back to the beginning of my career when with this addiction unit, so we were doing sort of research. Everybody was sort of pitching in doing this research, but I thought it was really important for them to have a stake in it. So we had a teaching conference every week. Lord knows what I was teaching them. I didn't know that much, but I was like every week we did teaching, and then when we would, whatever data we had that we'd gotten from these things, we shared, as opposed to, hey, collect this data so I can write a paper. So they were really interested in our patients. Like our patients, if you look at their depression scores, they go down, from here to 2 weeks by this much, except the people with major depression, they don't go down as much, et cetera. But it became, that gave them all a stake in what they were doing. And I think when you have a team sort of giving people a stake, involving them in something, in sort of educational activities, et cetera. One little thing we do, we have, as you know very well, we hold a conference every year that, for people in the audience, it's a really good conference every May, and so we pay for anyone in our entire swath, all of our treatment programs, to come to the conference. And when it was all in person, we'd get tons of people coming, and it was like a big team building thing. People loved coming to this conference and hanging out with each other, et cetera. So sort of trying to keep people involved in the in the bigger picture of what you're doing, I think is always important. And, I keep coming back to this thing, if you like the people you work with. When you hire nice people, it's really easy for everybody to be collaborative, because by definition, they are collaborative. When you make a mistake, as I have, and you hire somebody that's not collaborative, it puts a chill on the whole operation. And you usually don't know that that's going to be the case until you see it. But it's a poison. And it just, that's why I say, if you work with people you like, you'll always like coming to work, and when you don't, it's really different.
Yeah, Well, thanks for those reflections, and I would say I'd go back to one other thing you said earlier on, and it goes along with having a group of people who enjoy working together, is that you said when you're laughing a lot with the people you work with, you know something's going right. And I can attest to that because I have been a participant in those groups, and there is a lot of shared humor, and it is really very important and very helpful. I wanted to have an opportunity now. I have many more questions that I could ask, but I'm also wondering about the audience. We have about 10 minutes or so where I'd really like to open it up to audience questions. Is that okay?
Yeah, sure.
So I don't know if people have questions, but if you do, I think please come to the mic, and that would be great. And I see, and if you can, could you just say your name and where you're from, too, when you get to the mic, so everybody knows who's asking the question. So go ahead, Tom.
Is it on? Is it on? Yes. Okay. Well, I'm Tom Costin, and I come from the place that was willing to pay Roger less than he got at Harvard. The two questions I had. One is the collaboration that I'm probably more than, like 100% research and 80% clinical. And collaboration has become extremely important outside of not just, addiction psychiatry, outside of psychiatry. I mean, a lot of my collaborations are immunology, neuroimaging, a bunch of other stuff. And if you're not doing that, it's in fact increasingly hard to get grants. The other question is one that you don't have to answer if you don't feel like it, because I know it's like asking about, what's your sex life like, but it's money. A big impediment, I think, for academic positions for people coming out of their residency, at least that I hear, was, I'm in debt already, and I'm in a lot of debt. I can't afford academia. Now, my wife had a very good solution to that, because at my institution, becoming a psychoanalyst was something that, if you really were a psychiatrist, you'd become a psychoanalyst. And, I wasn't a real psychiatrist, and I didn't think I'd be a psychoanalyst, but I did my training analysis for about a year and a half anyway, at the end of which my wife said, you can either continue your psychoanalysis or we can buy a house. One of those choices comes with you potentially trying to find a new wife. And, that kind of... I wonder if you had similar experiences to that.
Yeah, actually, my plan when I finished my residency was to work on this general psychiatry unit and go into the Psychoanalytic Institute. I had a training analyst lined up who had a 1-year waiting list. And during that year, this whole addiction thing came up. And I said, I'll postpone it for another year just to see how this goes. And it went pretty well, so I stuck with it. But we were around the same time, right on the cusp of when psychiatrists, leading people in leadership positions, it was sort of required that you were an analyst or not. It was just around that time that some people were doing it and some people weren't. And so we both ended up on the other side of that. But the cost of that, ridiculous. Yeah. Yes.
Hi, my name is Jay. Can everyone hear me? I'm a medical student, a fourth year at St. Louis University in St. Louis. And thank you so much for the discussion so far. I love hearing about mentorship. I've been really lucky as a fourth year medical student to mentor M1s, M2s, M3s. So it's been really fun to be on that journey and continue to mentor people. But I was wondering, for you, how do you balance research and clinical work? I'm going to be going to residency. I know during residency it's going to be harder to do research. I'm going to try and keep up with it. But how do you keep a balanced life with that? As a psychiatrist, I think it's really important, wellness and self-care. So how do you balance the research without, digging too much into your weekends? I love going to the mountains. I love going to the beach. I also like doing psychiatry, of course. But how do you keep that balance?
So you asked about balancing research and clinical work, but then you went on to how do you balance work with the rest of your life? I mean, those are really two different questions, so why don't I start with the first one and then answer the second one. So the first one, I certainly do less clinical work than I used to. I mean, I used to, I started out as a full-time clinician, so, and the research was just around the edges. When my kids when they went to bed at 7 o'clock, so they were pretty little, I would work after they went to bed. That's when I wrote and stuff. Once they went to bed at 8 o'clock, I couldn't do that anymore because I was too tired at that point. But, and I had a very, this gets more to the work versus the rest of your life. You know, I love my job, but I love my family more. And that was, so back when I was running this inpatient unit, I was home every night for dinner at 6:15, except for Thursdays. Thursdays I stayed home in the morning with the kids, and then went to work at noon and worked as late as I needed to get all my paperwork done for the week. So that was just like the routine. And it was a lot easier then because there was no email. There was mail. People actually got mail, and there were phone calls, and that was it. But nothing else. So the only phone calls I ever got were clinical emergencies on the inpatient unit. You know, somebody fell down, was going to the emergency room, something like that. That didn't happen very much. When you were home, you were home. You're not always looking down going, oh, you know. So it is much harder now because it just sort of what goes into all through your life. You know, I don't have any magic answers on that. It's harder to set those boundaries. You know, I try my best. I think but I've always prioritized stuff with my family, and because that's always come first, you know. And there's ups and downs, all sorts of ups and downs that occur, but you have to have the priority. The research versus clinical thing. I think in writing grants and that sort of thing, it's always been this issue of, I'll see more patients if I don't get this grant. And I've been kind of fortunate that I haven't had sort of fallow periods for a while. So my clinical work has become less, you know, I've just done less clinical work, but I get involved I hear about a lot more cases than people that I'm actually treating.
So we have less than 3 minutes, and I'd love to be able to squeeze in both these questions if possible. So come on up and ask your question, and we're going to try to get to the next one too before we have to stop.
Hi, I'm Jacob Gutierrez. I'm an addiction psychiatrist working for the Ultimate Health System. My question was because you brought up this idea of having a collaborative team and how that makes work life a lot easier. What type of traits would you consider and people would be good team members in a collaborative team, and what would you call like a collaborative team? What do you consider to be collaborative? That's my question.
So what kind of traits that, do you look for in people who would be part of a collaborative team? Good question.
It's a great question. And I'll give you an answer that I'm not sure really. Well, when I interview people, whether it's for a job or any sort of position, it's, do I want to spend time with this person week after week, month after month, year after year? Do I like this person? I mean, obviously, I look at their CV and see, they've published and they've done this. That's the screening. The screening is on paper. Once you get to, okay, this person looks okay on paper, now what are they like? It's a pretty soft kind of thing, but if you hire somebody, you're going to spend a lot of time with them. Is that what you want? And if it is, I hire them. and if I don't really feel comfortable with them, I don't. I don't know if that's a good answer, but that's at this point, and it's worked out pretty well. So that's it.
So Nita, can we fit in this one more
last question?
Okay, last question.
Thanks, Dave Cundiff. Love that, and I would add that since we all have implicit bias somewhere, you need something that informs your choices as to who you want to spend time with in a way that is also just and fair in the big picture. I had a question, though. Obviously, your mentors and those you valued and who had power over you applied the right amount of stress to help you grow without ever applying so much stress that it broke you. In retrospect, that's wonderful. How do you feel in prospectively? How do you feel before you've said it, before you've done it? What's the right amount of stress to help your people grow without breaking any of them?
It's another good question. It's like the three bears. Not too much and not too little. I don't think when I'm mentoring somebody that I'm really thinking about, I want to stress them a certain amount or not. It's really, here's what I think you should, it's again, trying to put them in a position to succeed. I'll say, you need to do this, you need to do that, you need to do that. I don't do it for them, but I say you need to do these three things. And if you can do it, now you're on to the next thing. If you can't do it, then I have to make a decision. Do I think there's something that I can do to help them get to a point where they can do it? And if the same thing comes up repeatedly, then we have to have a conversation of, this isn't working. And a lot of times people say, I can't do that. I remember working with somebody writing, they were writing a paper, and I said, this paragraph doesn't follow from that paragraph. And they gave it back to me, and I said, this paragraph doesn't follow this paragraph. And this happened 3 times, and he finally said to me, I don't know what you're talking about. This is the best I can do. We tried to work on it, but it was like, that's not just sort of a technical thing to teach. It's just that the person was a fabulous clinician who was trying, a little more academic, and said, this isn't really for me. If this is what is involved, this writing, it's just not my thing. And then we reached a good agreement. Like, I tried it. It really wasn't my thing, and I'm going to stick with clinical work and teaching. I mean, this person was terrific, except not at that.
So I just want to thank you for wonderful answers to these questions
Yeah.
and congratulate you.
Thank you. Thank you. Thank you.
Thanks, Roger.
Right. That was really great.
It was great.